In this presentation, we will be discussing testicular complaints, including testicular torsion, hydrocele, varicocele, and testicular cancer. My name is Dr. Debbie Fahey, and I have been board certified as a family nurse practitioner since 2002, and I earned my DNP in 2014. My practice expertise is in emergency urgent care. I am a professor of nursing in the Orlando, Florida area and a visiting professor with Chamberlain. We'll start by discussing testicular torsion. Testicular torsion is a twisting or rotation of the testes around the spermatic cord, which is the blood supply to the testes. The lack of blood supply to the testes results in acute ischemia. This condition is considered a urological emergency, so in the primary care setting, you must be able to recognize this and immediately refer the patient to the ER. Compression of the testicular vessels will lead to ischemic necrosis within 6 hours, so failure to recognize the torsion and intervene immediately can result in loss of the testicle. Testicular torsion can happen at any age, even to newborns and older men. However, the majority of cases are seen in adolescent and young adult males. It is not a common condition, and its etiology is really not clear, but one theory is that contraction of the cremasteric muscle may contribute. Things that can cause contraction of the muscle include trauma, exercise, most frequent in runners, extreme cold, and sexual stimulation. The most common symptom in testicular torsion is sudden, severe pain accompanied by swelling of the affected testes. The patient may have pain for several days without seeking medical attention. The most common finding on clinical exam is the absence of the cremasteric reflex, and unlike in epididymitis, elevation of the affected testes does not relieve the pain. This is called Friend's sign. This finding is not enough to differentiate between the two conditions, but rather they can support your suspicion. The differential diagnosis for torsion should include epididymitis, acute varicocele, acute hydrocele, incarcerated hernia, and traumatic hematoma. Diagnosis is a clinical one, meaning it is based solely on the history and physical findings. The only assessment that is required is the physical exam of the scrotum, testes, abdomen, and groin. Again, because this is considered an emergency, if the patient presents to you in primary care and you have a high level of suspicion, send the patient to the ER and call ahead with a brief history and physical to the ER provider. In the ER, manual reduction of the testes is usually performed, and if not successful, will be followed by surgical exploration and may require removal of a non-viable testis. Viability of the testicle is directly related to the duration of torsion, so again, time is of the essence. If torsion occurred more than 6 hours prior, the likelihood of viability falls to 10 to 15%. Beyond 24 hours, the viability rate falls below 10%. There is also a reduced rate of sperm production in patients who have had torsion, whereby reproduction may be affected. We are going to now move on to a brief description of hydrocele and varicocele. A hydrocele is a collection of peritoneal fluid within the scrotum between the two-layered sac that holds the testes and spermatic cord. Hydroceles are also uncommon, less than 1% of adult men, but most occur in males that are older than 40 years of age. Causes of hydrocele include acute epididymitis, testes trauma, testicular tumors, and the sequelae of radiation therapy complications. History findings will complain of swelling in the scrotum or inguinal canal. They are usually painless and are reported as a sense of heaviness in the scrotum. The physical exam should include an examination of the scrotum, testes, abdomen, and groin. Additionally, transillumination of the scrotum should be performed. To do this, in a darkened room, place a pen light up against the scrotum. The trapped fluid from a hydrocele will appear light pink, yellow, or red. The testes themselves do not illuminate, and neither does a hematoma. This is typically considered a diagnostic finding. Diagnosis of a hydrocele is a clinical one. If a hydrocele cannot be confirmed by history and physical alone, the patient should have an inguinal-scrotal ultrasound performed to rule out inguinal hernia. At this point, if diagnosis is still unclear, a referral to a urologist is recommended where additional testing with abdominal x-rays or nuclear scan may be warranted. Differential diagnosis for hydrocele should include indirect inguinal hernia, orchitis, which is an infection of the testes, epididymitis, and varicocele. For adults, no treatment is required in most cases. If the hydrocele is painful, large, unsightly, or uncomfortable, several outpatient surgical procedures can be performed by a urologist. A varicocele is an abnormal degree of venous dilation in the vasculature above the testes. Varicocele incidence is around 10 to 20%, and there is no particular age group who are predisposed to it. Varicoceles are caused by weak walls and vascular engorgement in the spermatic cord. You can think of it as varicose veins of the testes. Patients may present with pain or engorgement of the testes. However, it is usually noted as part of a workup for infertility. The hallmark characteristic of varicocele is the sensation that the testes feel like a bag of worms. Varicocele can be bilateral, but if it is unilateral, it is almost always on the left side due to the anatomy of the vasculature drainage of the testes. On physical exam, with the patient sitting upright, tortuous veins located posterior and above the testes can be seen. Venous engorgement may increase with the Valsalva maneuver. When the patient lies down in the recumbent position, the distension will resolve. Diagnosis of a varicocele is mostly clinical and is again typically found incidentally on a workup for infertility. Men with varicoceles tend to have low sperm counts, and the motility of their sperm is decreased. Because a urologist or reproduction specialist is usually the one to find a varicocele, testing is not often done in primary care. However, a scrotal ultrasound, venography, or thermography all can confirm the diagnosis. The differential of varicocele should include a hydrocele, spermatocele, testicular tumor, and epididymal cyst. Most varicoceles are minor, but a referral to a surgeon is indicated. Embolization or ligation of the spermatic vein can be performed. Conservative treatment is the preferred management for older men with only minor pain or for whom fertility is no longer an issue. Testicular cancer. Compared with other types of cancer, testicular cancer is rare and is highly treatable. Testicular cancer is the most common cancer in American males between the ages of 15 and 35. There is no clear cause and effect relationship for testicular cancer, but risk factors include HIV infection, Caucasian race, and undescended testes. Other risk factors that have been identified include higher social status, being unmarried, and living in a rural area. Testicular cancer is usually found based on the symptoms a person is experiencing or when the patient or their partner finds a lump in one of the testicles not previously noted. Typically, the patient will report a painless lump in one of their testicles or a feeling of heaviness in the affected scrotum. As many as 10% of patients with testicular cancer will be asymptomatic, whereas another 10% will present with manifestations of metastasis, which may include lower back pain, generalized fatigue, swollen lymph nodes noted in the groin area, and weight loss. On physical exam, a firm, non-tender mass is usually distinct from the spermatic cord. Differential diagnosis of testicular cancer should include epididymitis, hydrocele, varicocele, hematoma, and spermatocele. To confirm a diagnosis of testicular cancer, an ultrasound is often the first test done. Some blood tests can help diagnose testicular tumors. Many testicular cancers make high levels of certain proteins called tumor markers, such as alpha-fetoprotein, AFP, and human chorionic gonadotrophin, HCG. When these tumor markers are in the blood, it suggests that there is a testicular tumor. A testicular tumor might also increase the levels of an enzyme called lactate dehydrogenase, LDH. It is important to remember, however, that a high LDH level often indicates widespread disease in many other conditions other than cancer. To make a definitive diagnosis of testicular cancer, the patient will need a biopsy of the lump found in the patient's testicle. A CT, MRI, and a PET scan can be used to determine if the cancer has spread to other areas of the body. Treatment for testicular cancer is determined based on the TNMS staging system. T stands for tumor, N stands for node, M stands for metastasis, and S stands for serum tumor marker. Treatment of testicular cancer usually starts with surgery to remove the testicle with cancer, called radical inguinal orchiectomy. The entire testicle and most of the spermatic cord are removed. Follow-up with chemotherapy and radiation are typically recommended. A multidisciplinary team that includes a urologist and a medical oncologist will create the patient's treatment plan. Most often, testicular cancer can be successfully treated with surgery, chemotherapy, and/or radiation. Your role as an NP will be focused around providing the patient with answers to their many questions and making sure that the patient gets the proper referral connections needed, along with providing the patient and family with support. In addition, you may be involved in helping to manage the patient's side effects associated with treatment. Males particularly have concerns regarding how their treatment will affect their sexual function, fertility, and quality of life. Prevention is important for all men in this age range. Teaching about a monthly self-exam is extremely important and cannot be stressed enough. All males age 15 to 40 years old should be instructed to perform monthly TSEs, and techniques should be demonstrated during routine preventative medical exams. The patient should perform a self-testicular exam during a warm bath or shower, or right after a warm bath or shower. The warmth relaxes the scrotum, making the exam easier. It is normal for one testicle to seem larger or longer than the other. Cup one testicle at a time using both hands. Examine by rolling the testicle between the thumb and the fingers. Feel for lumps or irregularities. Like all cancers, the earlier the diagnosis is made, the better the patient outcome.